Welcome back to the Physio Foundations podcast, where we talk about the knowledge and skills that provide the foundation of expert clinical practice. So on this episode, I'm talking to Associate Professor Annemarie Lee from Monash University Physiotherapy, a colleague of mine who I work closely with. And this is a two-part series that we're doing on an area of specialty of Annemarie's, which is bronchiectasis. So just a note before we start, if you found the podcast and you're new to the podcast after listening to some of the recent episodes that had a musculoskeletal and a sports focus, like Adam Colviner and Nick Kane and Mick Hughes and Randall Cooper, the last few episodes, and you say you describe yourself as a musculoskeletal or a sports physiotherapist, I really encourage you to dive into the content here because these episodes are an opportunity to broaden your knowledge on human health and physiotherapy management. And Annemarie herself is a really interesting guest who has a lot that you can learn from and broaden your knowledge to better your physiotherapy management. There's a lot of crossover here, a lot of transferable knowledge and skills between these fields. And that's one of the reasons to do this podcast, to share that knowledge. And a little bit about Annemarie before we start. So Associate Professor Annemarie Lee is a highly experienced cardiorespiratory physiotherapist. She's an educator with us, Monash Uni Physiotherapy, and a researcher. And her research work has helped shape how we understand and manage bronchiectasis in physiotherapy practice. We'll talk about that today. Annemarie's worked extensively in clinical and academic roles. She completed her PhD at the University of Melbourne, postdoctoral research with the Canadian Respiratory Research Network. She's worked clinically at Alfred Health, which is a major hospital here in Melbourne with a large respiratory service. Annemarie's known for her work co-developing the Bronchiectasis Toolbox and Strong Lungs websites. We'll talk about those today. These are incredible resources for clinicians and people with lung conditions. And Annemarie won't tell you this, but she was awarded the Lecturer of the Year in 2023 by Monash Graduate Association. And she's shaking her head at me now. And in recognition of her high-quality work in physiotherapy education. So it's a pleasure to get her on. I've embarrassed her enough. Let's get on with it. Annemarie Lee, welcome to Physio Foundations.
Thanks, Luke, for having me, and thank you for that very kind introduction.
Hopefully I've covered everything there. Anything else you'd add from your background and what's led us to today at this point?
I think the main thing for me is that when I first graduated, I went into cardiorespiratory physio and really found that was a great love of mine, and always had that interest and always worked in that area, both clinically and in a research sort of sense as well. So it's not unexpected that I ended up doing research in bronchiectasis.
Yeah. And so just before we get into the topic, you had your initial work, your initial foray into clinical practice would have been broad, and you learned about a lot of conditions, and you developed a clinical special interest and lots of experience, and now research profile and obviously education profile in your special area of interest. As a cardiorespiratory physio, you'd have expertise with you don't just do bronchiectasis though. You would have knowledge across a wide domain, I'd imagine.
Yeah, so effectively in my career, I've worked in both at the acute sector and also in pulmonary rehabilitation specifically. So across the acute sector, certainly covering different medical conditions, respiratory medicine, surgery, ICU earlier in my career. I'm probably a little bit more rusty around the clinical areas for that now. And in terms of rehabilitation, certainly had a lot of focus around pulmonary rehabilitation, but also the physiotherapy management specifically for bronchiectasis and people with suppurative lung disease. So bronchiectasis, cystic fibrosis, and specifically prescribing airway clearance and exercise sort of therapy for those populations.
And knowledge of those conditions and generally of different systems of the body is vital, as I was saying before, for, say, a musculoskeletal or a sports physiotherapist. Maybe when you're a student and an early grad, you haven't seen that connection yet, but it's an overall health of the person that you have to consider. But we won't go down too far down that pathway. I'm sure people can make that connection themselves. What is bronchiectasis? What are the different types of bronchiectasis and their causes? Let's talk about that.
So bronchiectasis is considered a clinical syndrome, And its key features are infection and inflammation within the lungs. And that tends to lead to patients having issues around a chronic cough with usually chronic sputum production. And that sputum is usually what we call purulent or coloured. They would also experience some dyspnea and fatigue as a result of that infection and inflammation. And that tends to be a cycle that they would sort of experience. And it's a non-curable condition. So people can certainly live with bronchiectasis and live with bronchiectasis well and stay relatively healthy or very healthy in some cases. But there is no sort of cure beyond people actually having a lung transplant should their condition be severe enough sort of overall. So you're really looking at in a pattern of infection, inflammation, and recurrent sort of exacerbations would tend to characterise the clinical sort of picture.
Mm.
There's lots of different causes of bronchiectasis. So some of the most common ones would be after a really bad respiratory infection. So it might be a bad bout of pneumonia or in the early days. So we're talking, early 20th century, a lot of people who had sort of whooping cough or measles that affected their respiratory system might have gone on to develop bronchiectasis as a result of that. We obviously don't see that as much now because of vaccinations. Some people will also have it as a result of different changes in their immune disease, so changes in terms of their immune system's ability to have certain immune markers and therefore be able to fight off infection. It can also be associated with other systemic diseases such as rheumatoid arthritis. So there you've got that link with a musculoskeletal condition. And a lot of people would actually not have a known cause, and that's what's referred to as idiopathic bronchiectasis. So that would probably affect at least 25% of people who are diagnosed with the condition.
So the symptoms and how they impact people is an obvious link with all the other different fields of physiotherapy. And you mentioned one a condition, rheumatoid arthritis. So people's symptoms, chronic cough, shortness of breath, fatigue, a cyclic process. So they're any other symptoms that you would add there?
Probably the other one, which is, I guess they evolve secondary to that chronic cough, fatigue, dyspnea, is having a reduced exercise tolerance. And that obviously has an impact on someone's quality of life and well-being. And when we talk about quality of life, we can talk about cough-related quality of life because coughing is such a big part of their clinical picture. But we can also talk a little bit more specifically for their disease quality of life as well. And that tends to be poorer compared to their essentially age-matched controls across the board, whether they be of a paediatric child age or all the way up to different levels in terms of adults.
In the last episode, we were talking about not just treating the knee, treat the person with Randall and Mick. Now we're talking about not just treating the lung and the condition. We're talking about all the flow-on effects, quality of life, reduced well-being. And obviously we want to help people with those. And that's what you've been focusing on with your clinical and education and research work. So what about functional limitations? So exercise tolerance is reduced function. Any other flow-on effects from these symptoms? You might have covered them all.
Yeah, no, there's certainly, when we talk about reduced physical function, that also can lend itself to reduced physical activity levels and the ability to sort of engage in exercise as well. And I think the other thing that's really apparent with bronchiectasis, and this can apply to other chronic conditions as well, is that a lot of the coughing that people experience puts a lot of stress on their pelvic floor. So incontinence is not an uncommon problem for both males and females with bronchiectasis, and it certainly can affect children as well as adults. We also know that reflux can be a sort of, a common comorbidity that can be an issue. And they might also have musculoskeletal pain, again, from that chronic coughing where they have a lot of back pain or chest pain just because they're doing repeated episodes of coughing or needing to do that as part of their airway clearance therapy.
So I'm learning, and I hope our listeners are learning from this as well. And one learning point there is that someone may come into your private practice with low back pain, and that this may be part of their history, and this may shed some light onto potential causes of the reflux or incontinence that may or may not be reported, or
Absolutely.
low back pain. Yeah. So, and just we refer back to Jody, who's been on Jody Dakey, previous episodes, talking about her screening work for women in sport with incontinence. Then you mentioned men's health. It's not just women, it's men as well. Yarp Switters has been on talking about men's health, pelvic pain, continence. I'm just making links between different conditions in the body. And we're not just talking about lungs here and lung health. So there's a huge impact on people. What about length of life? So that's quality of life. What about duration of lifespan?
Depending on the severity of someone's bronchiectasis, it could be life-limiting. So I don't have the exact stats with me at the moment. I'm not like Bruce McAvaney, where I might have that right in my head.
I just threw that one out.
In terms of, what the sort of duration, but it is a progressive disease. So people certainly can experience deterioration in their lung function over time, but the rate of that deterioration will be very much dependent on the severity of the condition, the treatment that they're currently having and how effective that is. And from that perspective, I'm talking both a medical and a physiotherapy type of approach, how compliant they are with that, and I guess other complications that sort of might arise as well. So there's certainly a number of people who can live very, very well and very fulfilled with this sort of condition, and others who might experience many more challenges just because of the, whether it be related to the different cause or those other factors that I mentioned as well.
And perhaps quality of life has improved in recent decades with availability of resources that we'll talk about soon, and better treatments.
Absolutely. And I think one thing, I know we'll talk about physiotherapy specifically, but one thing that's really emerging and has emerged in the last few years is new medical treatments, specifically addressing inflammation and the markers of inflammation in this condition. And having been to a couple of conferences in the last 2 years where the results of different trials are being presented, it's a really exciting time from a medical perspective in terms of advances for treatment. And hopefully this will continue to sort of springboard in terms of being able to advance that aspect of treatment for this population as well.
Yeah, and we work together, patients, carers, doctors, physios, allied health. So it's really important to consider the medical interventions that are happening alongside physio interventions. So that gives us a really good overall picture of the person and the condition. And we're going to talk about airway clearance, but we had on our list to talk about objective and subjective assessment. So we might call it a patient interview in history, or you might call it subjective assessment, depending on where you were trained. And that would include our symptoms and related to those impairments and functional limitations and the person themselves. What about the physiotherapy objective examination, or you might call that the physical examination if you were from a different uni? So what sort of things do you assess and then reassess with people?
Yep. So in terms of I always call it the objective assessment, certainly getting an idea of their vital signs, and that might be really important, particularly if someone's experiencing an exacerbation and they might be having more challenges with their oxygen status compared to when they're clinically well. Doing measures of their auscultation. So it's not uncommon to hear coarse crackles or bronchial breath sounds for someone who has a chest infection. When they're well, you might not hear any sort of specific changes in terms of breath sounds. It again will depend on the severity of their condition sort of overall and what their usual clinical picture is. So if someone is coughing up a lot of phlegm and that is part of their daily sort of experience, then they're more likely to have a lot more interesting sounds, I would say, in terms of their auscultation. From another objective perspective, certainly getting a measure of their dyspnea, and in particular their functional dyspnea. So one of the measures that we might use is the MMRC, so the Modified Medical Research Council scale. But if someone is also really troubled by dyspnea and it's having, seeming to have a more significant effect, We can also get some other more detailed measures that not only provide us information about the sensory effects of their dyspnea, but also the effect on their mood and their sort of emotional response to that. So there's some tools out there for that. It's also not unusual for some people with bronchiectasis to have what we call a breathing pattern disorder, where it often develops because every time they try and take a deep breath, especially if they have a high volume of sputum, that it causes them to cough. So they might develop the habit of actually breathing above their phlegm, and essentially therefore breathing much more shallowly and recruiting their diaphragm to a lesser sort of extent. So looking at someone's breathing pattern, it may also be important, depending on what you're actually sort of noticing in your objective assessment as well.
Sorry to jump in. That's a foundational skill of assessment, isn't it? So when you say breathing pattern assessment, observation, using your hands on their ribs and stomach, feeling the tension of muscles, how would you add anything to that?
No, I think I agree. And I think sometimes as physios, we neglect the power that palpation of someone's breathing pattern, particularly when they have a chronic lung condition like bronchiectasis, can actually tell us and what information we get. So there's nothing better sometimes of putting your hands on someone's chest and feeling where that breathing is actually occurring, and being able to tell also whether they're recruiting any of their accessory muscles as well, and therefore have a more of an upper chest breathing pattern compared to a lower chest breathing pattern, because that certainly might influence how well they're able to clear secretions, and perhaps what other techniques you might need to teach them to be able to adjust or improve or normalise their breathing pattern, so that that's not a factor that's preventing secretion clearance as well.
And you might apply that outside of a respiratory clinic with someone, say you mentioned low back pain earlier, and a history of respiratory or chronic obstructive pulmonary disease. And now you're broadening your understanding of the person and their condition, and you might actually start assessing their breathing and think about the role of holding their breath on the pelvis. And you mentioned incontinence, maybe their back pain. So it's all connected, of course.
It is all connected. And there's one physio in the States, Mary Massery, who's done a lot of interesting work that talks about the trunk and back pain and the pelvis and the ribs and the pattern of breathing. And that's certainly an area that can feed into, especially when someone's experiencing musculoskeletal pain, and if they've got that history of a respiratory condition, even if it's something like asthma, that might be a contributing factor, large or small, in terms of their clinical sort of presentation overall.
What anything else that we would assess objectively? So vital signs, auscultation.
I think always getting the patient to cough if they haven't already done so during your physical exam. And I also think it's important to get a measure of their exercise tolerance. So you can either do that by asking them, what activities and what are the limitations of their activities, or you might do it through a formal test like the 6-minute walk test or the incremental shuttle walk test or one of the step tests. And that will just give you a little bit more sort of insight in terms of their functional sort of limitations, particularly if they've said to you in their interview that they are feeling they've got difficulty with completing some sort of activities during the course of their day, and it's therefore helpful to get that sort of added information. And we've also got lots of quality of life tools that have been validated in the bronchiectasis population, and therefore can actually give you a really nice sort of overview of what someone's health status or well-being actually is. So some tools were developed not specifically for bronchiectasis, but have actually been validated in the population. And we've also got ones now that are validated, like the quality of life bronchiectasis and the bronchiectasis health questionnaire, that are specific for that patient group.
As we all increase our knowledge and awareness of things, we might pick up people with these symptoms at early stages. Are there a lot of people out there without, underdiagnosed or not diagnosed, or in the community, or they tend to get picked up through their GP and
It's
when they're
getting,
ill?
yeah, it's getting better. So it's better than what it used to be. It used to be considered an orphan disease or a rare lung disease,
Right.
but the index of looking at it is certainly much better than what it used to be. But there is still room for improvement, I will say, in terms of being aware of it in the community and really listening and investigating different symptoms that a patient might experience, and therefore making sure that the appropriate tests are actually done to help with that diagnostic.
Well, another good reason to have this chat.
Absolutely.
Which is, of course, as I say every time, or in the show notes, I put that in there. It's a conversation directed to health professionals and health profession students. And if anyone else benefits from it, and for general knowledge, fantastic. But of course, see your own health professional rather than listening to Luke and Annemarie on a podcast for your own health needs.
Yep.
Disclaimer done. So we're going to talk about airway clearance. We understand that what we're trying to improve. So the flow of air through the airways, the sputum you mentioned that builds up, that can lead to episodes of further obstruction, infection. And so breathing, and you mentioned the problems with breathing. Did you say breathing above the phlegm? Did you say?
Sometimes that can happen for some patients.
The shallow breathing pattern, and you assess that. And we want to improve breathing. That's going to lead to better exercise tolerance and quality of life and how people feel. So what are the techniques? Are they I guess a double barrel question. Are these a specialty technique that you have to have training in, or is it more something that all physios should know about, even if they're not in cardiorespiratory full time?
Yeah, I think it's important for all physios to be aware of, and certainly in our undergrad and postgrad program, we would teach them, and I think most universities would, in terms of the basics of airway clearance. So there's been different research in this sort of field, and there's certainly a recommended part of management in both international and national guidelines for bronchiectasis. There's no one technique that's better than the other. But we've got lots of options. And they can be categorised in probably 3, maybe 4 different ways. So you've got the first group, which I consider to be sort of positional, which is a little bit more traditional, where it's gravity-assisted drainage, and that might be supported by either some specific breathing exercises or some manual techniques like percussion and vibrations. The next group would be around specific breathing exercises, where it's the active cycle of breathing technique, the forced expiratory technique, which also forms part of ECBT, and also autogenic drainage, which is a little bit more of an advanced technique. And then you've got the options around devices, and this can either be the handheld devices where you've got PEP masks or mouthpiece PEP, or different forms of oscillating PEP like the aerobica or the a cappella. And we also have some more, I guess, bigger items, which are could be classed as benchtop devices, where it might be using the vest, which is certainly highly used in America as opposed to Australia because it's very expensive, or a device known as the Semiox, which is essentially helping to sort of clear those secretions. And some patients will also use exercise as a form of airway clearance technique as well. And there's a bit of debate as to which category that falls into, but I'd probably put it into the breathing one as opposed to the other two.
The exercise is specifically aimed at the quality and the depth of breathing to really address that. So the mechanism there is you're getting airflow behind and moving. You've got impaired mucociliary clearance. You've got impaired movement of sputum, up out of the lungs, and it's getting air behind it and breathing with coughing. I realize this is very basic stuff, but it's so important.
Yeah, I think there's different mechanisms that will work for different types of techniques. So, the one that you were talking about before certainly could apply to the different sort of breathing exercises, but there are elements of that would also work in terms of the handheld options like PEP therapy, where essentially you're trying to build up a little bit of air behind the secretions to then be able to stabilise the airways and provide some vibration that might actually sort of physically help the secretions to sort of loosen off the airway wall. So there's various different sort of mechanisms that might be in play depending on the device or the technique that's chosen.
Now, I'm looking at the Bronchiectasis Toolkit website. Bronchiectasis Toolbox website. The link will be in the show notes, bronchiectasis.com.au/physiotherapy, that summarizes all of this. So if you're taking notes, good for you, but maybe have a look at the website, save some note taking. Fantastic resource. This one is for, we'll go into the background of it, but this one is for patients, carers, families, plus health professionals. Is that right?
Yeah, it was originally designed for healthcare professionals. So the language is, and the resources are essentially targeted towards that. But we certainly know that a lot of patients and their carers do use it. So whether it be for looking at the videos, they're probably one of the most popular things, or where can I buy a specific sort of device? So it's both. Essentially, it's being used by both healthcare professionals and patients and their carers overall.
Yeah, so it covers a lot of the background information you've given us about bronchiectasis diagnosis, management, medications, assessment, medical physiotherapy, outcome measures you've talked about, principles of airway clearance, techniques, exercise, implications for different cultures, Indigenous cultures, medical physiotherapy, resources, pediatrics, so information for children as well. So that's really worth looking at as a central place to summarize this information. What's the background there? So you co-developed?
Yeah, co-developed it with Caroline Nicholson, who is a now retired respiratory clinician. So she worked at the Alfred as well as various other places over the years. So I think it was initially launched in December 2015 from my recollection. So it's been going for about 10 years, and it has undergone at least one comprehensive update, and we're just about to start the next one. And we're lucky enough to have it endorsed by the Thoracic Society of Australia and New Zealand. But it's certainly a globally used resource. So a few years ago, we looked at the number of hits and it was over 1 million. And I'm sure that number has kept sort of growing. And certainly, a lot of people are sort of looking at it overall for different points of information.
So it's endorsed and promoted by societies and other clinicians, of course. It'll be on hospital websites, linking people out to it. That's really amazing. I've got so many questions related to how you would go about getting something that 1 million people refer to, but they're probably
that might be a separate podcast, Luke.
It could be a different conversation, but it obviously indicates that it's there's a need for that information. Is there any other ways of evaluating the impact of the website beyond hits? It's I guess you'll have a lot of people telling you that how they've used it.
Interesting that you asked that. So I currently have a master's student who is looking as one of her projects to be evaluating web-based resources, and she's starting with a systematic review of all the different web-based resources with specific criteria, but then she's going to undertake a evaluation from a healthcare professional perspective of the Bronchiectasis Toolbox specifically. So hopefully once that study is underway and we have some results, that will certainly give us a little bit more information about how it's perceived, but also, and more importantly, suggestions for what else might be sort of needed or what could be sort of, updated, because we consider it to be a live document, so to speak, and it needs to be contemporary. And this is a space that, like so many things, is constantly changing. So the need to be able to make sure that it's relevant and stays relevant is really important to Caroline and myself in terms of the resource.
So interesting and so good to have something there in addition to the information you might get in person from a health professional or a community as well for people. Are there any other not just resources, but what's a good way to ask this? Where can people go to read and learn further about the topic? And are there any other resources you direct people to?
One specifically that I'll talk about is one that was developed for First Nations Australians, and you mentioned this in the intro. So What we do know is that the prevalence of bronchiectasis in First Nations Australians, both from a paediatric and adult perspective, is much higher compared to the non-First Nations population. And the level of clinical care is certainly challenged by a number of different things, one of these being language and one of these being geographical locations and access to sort of care and resources as well. So Caroline and I both recognise that, Caroline in particular, who led this project, and together we developed the Strong Lungs website. So this certainly has, it's a smaller website than the Toolbox, but it has specific resources for people caring for First Nations Australians. It was developed with a couple of communities in the Northern Territory, so certainly one known as Danila Dilba, which is based in Darwin, and the other one is out at Maningrida. So we certainly met with various different stakeholders, as well as those who work in the community care and also the Royal Darwin Hospital, to find out what they would like to have included. So that resource has a number of different videos, certainly not the same extent in terms of airway clearance, but ones that are probably most appropriate and needed based on feedback from the stakeholders for different techniques to be applied in these sort of populations. But it's also got some general information about the importance of just exercise, keeping healthy, and general health advice such as smoking cessation. And one of the big points with this website is that the videos, and there's about a series of 8 or 9 videos, they're available in English, but they're also available in other local languages specific to certain communities. So this is an area, again, that's growing. We hope with more funding we might be able to put some more language options on there, but it's a good starting point, and it's the only one that actually has these videos in language available in terms of providing this information for our First Nations population. So, our little step towards closing that gap, essentially.
What a great resource. And it'll be really interesting to see how that, the impact that has and how the evaluation of that goes. So the Strong Lungs URL will be in the show notes as well. It's very easy to find. If you type Strong Lungs bronchiectasis, it appears. So encourage everyone to have a look at that. And it was a nice segue there to the next episode, which we're going to talk about exercise, which is a huge topic, exercise in bronchiectasis. So let's wrap this one up there, and then listeners can wait for the next one come out. So Annemarie, thanks very much for sharing your expertise with us today, and we really appreciate it. Really good to hear from you.
Thanks for having me, Luke.
So everyone, stay tuned for part 2 of the conversation. And do us a favor, if you're finding this interesting, if you're going to be using it yourself in clinical practice, if you're mentoring somebody who will refer to this information, go ahead and share the episode as well. Not making money from the podcast. It's a part of my academic work. I have an interest in having really interesting conversations and sharing information with people who need it. And thank you for those of you who have contacted me with your episode ideas and your feedback on how you've been using the information from the guests on the episodes. It's been really good to hear from some of you. So keep listening, keep sharing. And until next time, till next episode, this is Annemarie and Luke wishing you all the best with your studying, professional development, and lifelong learning.